Evening, everyone, and welcome to Medical Emergencies in the dental office. My name is Dr. Ellen Grimes. I am the Dental Hygiene Program Director at the Vermont Technical College, and I have been teaching medical emergencies for a long time, over 30 years, I think now. I do hope that you will learn something new in the course this evening that can help you if an emergency were to happen in your dental office. So let's get started. There are 6 objectives for this course. One is to understand why you should have at least baseline vital signs for all of your patients. Second is to understand why it is important to practice emergency simulations. Third is to understand the importance of CPR in relation to medical emergencies in the dental office. Fourth is to identify essential equipment for your emergency kit. This webinar will cover information related to 5 particular medical emergencies, including their symptoms and management. So before we get started, we would like to start off by learning a little bit about our audience. So I would like for you to take this poll and tell me about your profession, please. Wonderful. So we have quite a few dentists and some dental hygienists and some dental assistants, 1 dental therapist, very exciting, and then some others. So I'm thinking that maybe the others might be some students, but I'm not sure about that. But so welcome, and I'm glad the polling works. I was worried about that a little bit. So let's get started here. So medical emergencies can and do occur in the dental setting. There are approximately 150,000 emergencies in dental offices each year. Studies have determined that each United States dental office has 7.5 emergencies over a 10-year period. So that's approximately 1 emergency per year. The most common emergency reported was syncope, followed by mild allergic reaction, angina pectoris, and orthostatic hypotension. As one would think, medical emergencies were most likely to occur after the administration of local anesthetics and during tooth extractions or endodontic treatment. It is predicted that due to the increasing age of the patient population, as well as advances in healthcare with pharmaceuticals, surgery, and life-prolonging treatments, there will be an increase in medical emergencies seen in the dental setting. So, I have a second poll. Can you tell me if you have experienced an emergency in your dental office? So let's see if we can get to this poll. And if you could let us know. Wow. So that is very interesting. So the results are that 58% of you have had an emergency in your dental office. So as I said, emergencies definitely do happen in the dental office. Taking a complete and accurate medical history is essential to help prevent a medical emergency, as often a patient will report a medical condition that should signal the dental practitioner of the increased risk of a possible emergency. It is also important to update that medical history at each visit, as it often changes over time. Examples of medical conditions where the medical history provides important evidence include, but are not limited to, the history of a heart condition, asthma, a stroke, frequent headaches or epilepsy, thyroid problems, diabetes, corticosteroid use, allergy, and bleeding disorders. If the patient were to report any of these conditions on their medical history, the dental practitioner should dialogue with the patient further to gain information in an effort to prevent a medical emergency from occurring. Questions regarding the frequency, severity, and triggers should be asked to determine the likelihood of an emergency occurring. Oftentimes, it is better to postpone treatment until the patient has been examined by their medical physician. Another important aspect in the prevention and management of medical emergencies is taking and recording the patient's vital signs. Vital signs include pulse, respiration, blood pressure, and temperature. Until the advent of COVID-19, temperature was not regularly taken in the dental office. However, as we know, it is taken on every patient now. Hypertensive or hypotensive patients are more likely to experience various medical emergencies. This is also true for patients who exhibit tachycardia, bradycardia, tachypnea, bradypnea, or dyspnea. Having baseline vital signs for comparison during a medical emergency is essential. In a healthy adult, the normal pulse rate is approximately 60 to 80 beats per minute. However, individuals who exercise routinely may have lower pulse rates in the range of 40 to 60 beats per minute. A normal respiratory rate for an adult at rest is 12 to 20 breaths per minute. A normal adult reading for systolic blood pressure is 100 to 120 millimeters of mercury, and a diastolic pressure is 60 to 80 millimeters of mercury. Hypertension is the most common primary diagnosis in the United States, with 60 million Americans being affected. 70% of Americans are unaware that they are suffering from hypertension. Therefore, it is imperative that dental professionals accurately assess the blood pressure for each patient they treat. The American Heart Association recently developed a new blood pressure classification system. In the system, there are 4 classifications of blood pressure: normal, elevated blood pressure, stage 1, and stage 2 hypertension. And these are listed on the table that you see on your screen. Normal blood pressure is less than 120 systolic and less than 80 diastolic. Elevated blood pressure, formerly pre-hypertension, is 120 to 129 systolic and less than 80 diastolic. Stage 1 hypertension is 130 to 139 systolic or 80 to 89 diastolic. And stage 2 hypertension is greater than 140 systolic or greater than or equal to 90 diastolic. Dental professionals should refer any patient with a blood pressure reading over 120 over 80 to their physician for evaluation. I know that finding the time during difficult, but it only takes 10 seconds, and you multiply that by 6 for the pulse, 15 seconds, multiply that by 4 for respiration. And if you use an electronic blood pressure cuff, it shouldn't take more than 35 seconds. So altogether, it should only take 1 minute to take vital signs, which could save your patient's life. So now we have another poll. I'm just trying to find out, do you take blood pressure at each appointment for your patients? And let's see. So I'm just going to share these results. So 46% do. Congratulations, that's very exciting. 24% do not, 21% occasionally, and 10% only if a patient reports a history of hypertension. I'm hoping that after this presentation tonight that maybe that 46% will actually increase. Dental professionals should be prepared for any emergency that might occur in their office. A well-equipped medical emergency kit, automated external defibrillator or AED unit, and a portable oxygen tank are a necessity. These items need to be monitored regularly to ensure that they are current and in working order. You also need to know how to work each one if you need to as well. Several injectable and non-injectable drugs will be presented during this course. A complete list of contents recommended for an emergency kit in the dental office can be found in Chapter 2 of the Grimes textbook, Medical Emergencies, Essentials for the Dental Professional. An AED, or automated external defibrillator, is designed to reverse the irregularity of the heart. Since dental offices are healthcare providers, they should all include AEDs. The AED that you purchase should be easy to use, should walk you through the steps of CPR, and deliver shock only if necessary. You purchase an AED hoping you never have to use it, yet when you need it, it will be there and you will be ready. In addition to having an AED ready, keeping your CPR certification current is essential if you are to manage any medical emergencies and save your patient. It is recommended that dental professionals be current in healthcare provider CPR that includes instruction in adult, child, and infant CPR and airway obstruction. The more you practice CPR, the easier it will be to remember the steps if a real medical emergency were to occur. In addition, CPR changes as research determines the most effective method to improve patient survival. Since emergencies do not occur on a regular basis, thankfully, and can happen without warning, practicing simulated medical emergencies within the office is an important preparatory aspect. These simulations ensure that each individual understands their role should an emergency arise and will reduce the anxiety associated with emergency situations when they do occur. So here's one more little poll. Do you practice emergency drills in your office? So it looks like about half of you do and half of you don't. And there's some offices that actually practice it 3 times a year, which is outstanding. I commend you for that. I'm hoping that the 47% of you that do not, if you can try to initiate that in your office, I'm certainly think that that will enhance your office and help if an emergency were to occur. So now we will discuss several emergency situations that could occur in your office. So here's the first scenario. Your patient, Neil Nervous, is scheduled for 1 quadrant of periodontal debridement with anesthesia. Neil is a 37-year-old plumber in excellent health. He has no positive responses on his medical history, but states that he had an unpleasant dental experience as a child and dreads coming to the office. He's obviously very anxious about his appointment today. After completing oral hygiene instruction, his face becomes pale and he is trembling. You notice that his skin is cold and clammy, and suddenly he loses consciousness. Most likely, Neil is suffering from syncope. Syncope is defined as a sudden, transient loss of consciousness and postural tone with spontaneous recovery, most often caused by loss of cerebral oxygenation and perfusion. This lack of cerebral oxygenation is also referred to as cerebral ischemia. Syncope is often associated with a stressful situation such as a dental appointment, and specifically the administration of local anesthetics, and it is the most common medical emergency to occur in the dental office. Most of you have experienced a syncopal episode at one time or another. My latest syncopal episode was the day after having some oral surgery. I had planned to go to work, so I jumped into the shower and was shampooing my hair and felt a bit dizzy. But I thought, I'd be fine. There's no way that I'm going to have syncope. Unfortunately, my body had other plans, and I went down half in and half out of the bathtub. I woke up a few minutes later and laid on the rug with my feet elevated and recovered from my syncopal episode. Needless to say, I called in sick to work that day. Syncope can also be caused by a change in quality of blood perfusing the brain, often caused by chemical or metabolic changes such as hyperventilation, hyperglycemia, hypoglycemia, ingestion of drugs, or acute allergic reactions. Or it can be caused by alterations in the brain itself, such as occurs during an epileptic seizure or CVA. There are various forms of syncope, and they are generally classified into one of three distinct categories: cardiac syncope, non-cardiac syncope, and neurocardiac syncope. Cardiac syncope results from inadequate cardiac output and usually occurs as a result of serious underlying heart disease. Electrical problems or arrhythmias or mechanical problems, obstructions within the heart muscle are common etiologies of this type of syncope. Non-cardiac syncope has a wide scope and includes but is not limited to such entities as syncope from seizures, orthostatic hypotension, situational occurrences, hyperventilation, and metabolic diseases. Neurocardiac syncope, the most common type of syncope, is known by various identifiers. It's known as vasodepressor syncope, vasovagal syncope, neurocardiogenic, or neurally mediated syncope. The exact pathophysiology of this type of syncope is still under investigation. However, most agree that it is usually associated with some type of noxious stimuli, such as pain, fear, exhaustion, or acute illness. Some dental patients are uncomfortable in the dental atmosphere, so for them, the anxiety produced by visiting the office can be extreme and can lead to the physiological responses that produce syncope. The initial response to this stressful situation is activation of the sympathetic division of the autonomic nervous system, inciting a fight or flight response. A release of catecholamines, epinephrine and norepinephrine into the circulatory system produces an increase in the blood flow to many tissues, particularly the peripheral skeletal muscles, in preparation for movement of these muscles, for you to run away from whatever is causing you the pain or the fear. From the tissues, the blood will be pumped back to the heart. However, we generally do not allow our fearful dental patients to run from the dental chair. Instead, we ask them to remain seated while we perform our procedures. The blood remains in the peripheral blood vessels and pools in the extremities, causing a hypotensive response, bradycardia, and a decrease in cerebral blood flow, leading to syncope and loss of consciousness. Signs and symptoms of neurocardiac syncope appear several minutes before the actual loss of consciousness. Presyncopal or prodromal symptoms directly correlate with the sympathetic stimulations and include pupil dilation, diaphoresis or cold sweat, excitation of the piloerector muscles resulting in goose flesh. Also, patients may complain of dizziness, vertigo, or nausea. If a decrease in cerebral perfusion exists, yawning and sighing may occur. Also, there may be some visual changes, particularly darkening or blurring of vision, seeing spots, shortness of breath, and palpitation or chest pain. Lastly, the blood pressure and heart rate may be elevated as a result of sympathetic stimulation. Onset is generally slow for neurocardiogenic syncope, and the dental professional may see the patient become pale prior to having the syncopal episode. Once unconsciousness has occurred, syncope is diagnosed, and there will be a decrease in heart rate, resulting in a weak, slow pulse of less than 30 beats per minute. In addition, the patient will exhibit shallow breathing, a decrease in their blood pressure, and possibly seizures if the brain is deprived of oxygen for a considerable period of time. So even though we don't always think of syncope as being too dangerous, it certainly can be. When the pre-syncopal or syncopal symptoms are recognized, all dental procedures should be suspended and all objects should be removed from the oral cavity. The patient should be placed in a supine position with the patient's legs slightly elevated to facilitate blood return. Additional procedures should include opening the airway and assessing circulation. All tight clothing, such as ties or belts that can decrease blood flow to the brain, should be loosened. Oxygen should be administered at 4 to 6 liters per minute, and vital signs should be monitored. Placing the patient in a supine position is usually sufficient to restore consciousness. If bradycardia continues, 0.6 milligrams of atropine can be administered to block vagal stimulation, which will increase heart rate. However, this drug should only be administered by trained personnel. Once the patient regains consciousness following the syncopal episode, they should remain in a supine position until they feel well enough to be returned to a seated position and their pulse rate returns to normal baseline reading. A cool, damp towel should be placed on the patient's forehead to help with recovery, in addition to providing reassurance and empathy, because it could be embarrassing for the patient. Patient should be repositioned slowly so as not to induce a reoccurrence of the syncopal episode. Attempt should be made to determine the cause to avoid future recurrence of the condition. All dental treatment should be suspended for the day, and arrangements should be made to have an emergency contact escort the patient home, since syncope can recur. Reoccurrence of another syncopal episode is at higher risk level for the first 24 hours following the event. Anti-anxiety medications may be advised for future dental or dental hygiene appointments. And if cardiac or non-cardiac syncope is suspected, the patient should be transported via EMS to the nearest emergency facility for definitive diagnosis. So that being said, let's see what we learned. So tell me, if you would please, what is the most common type of syncope in the dental office? Vasovagal, cardiac, or non-cardiac? Well, great. Most of you did get it right. The answer is vasovagal, which is also termed neurocardiac or neurally mediated. Thank you. In the second scenario, your patient is Manny Metal. He's a 55-year-old steelworker. He reports that his present health is fair. You review the medical history and note that the patient has a heart disorder for which he takes nitrostat as needed. He tells you that he is a little tense at the thought of you scraping under his gums. Suddenly, he has a burning pain in his chest, left arm, and shoulder. He is having difficulty breathing and has a pale color to his skin. There are several conditions from which Manny might be suffering. However, due to his history of taking nitrostat as needed, he is likely experiencing an anginal attack. Angina is a form of ischemic heart disease, IHD. Ischemic heart disease, or myocardial ischemia, is a pathologic condition of the myocardium caused by lack of oxygen to the tissue. IHD and its associated complications result in the greatest number of deaths each year in the United States. Atherosclerosis of the coronary arteries is the most common cause of myocardial ischemia and subsequent myocardial infarction or heart attack. Atherosclerosis is a common arterial disorder characterized by yellowish plaques of cholesterol, lipids, and cellular debris on the inner layer of the walls of large and medium-sized blood vessels. Ischemic heart disease has several predisposing factors, such as diet, high blood pressure, smoking, diabetes, obesity, decreased physical activity, increased stress, and heredity. If your patient exhibits any of these factors, the dental professional should inform them of their increased risk of atherosclerosis and coronary artery disease. Dental professionals will undoubtedly treat patients that present with diagnosed or undiagnosed IHD. A thorough evaluation of every patient's medical history is critical prior to the initiation of any dental treatment. So your patient this morning, Manny, is most likely suffering from angina, which is one of the more common emergencies encountered in the dental office. The major symptom of angina is discomfort, a burning or tightness in the chest from transient and reversible myocardial oxygen deficiency. The key words here are transient, meaning the symptoms come and go, and reversible, meaning the myocardial oxygen deficiency can be reversed by medication or reduction in the workload of the heart. There are three types of angina: stable, unstable, and Prince-Metal's or variant angina. Stable angina presents with predictable and reproducible discomfort in the left area of the chest lasting anywhere from 1 to 15 minutes. It is usually induced by physical activity and/or stress, and the symptoms are often worse in cold weather or after a large meal. Stable angina responds positively to rest and/or the administration of nitroglycerin, usually within 10 to 15 minutes. Angina is considered stable if the patient has had no changes in the frequency or duration of symptoms within the previous 60 days, or there have been no changes in the precipitating causes of the attack. Unstable angina is also known as pre-infarctory angina, coronary insufficiency, crescendo angina, intermediate coronary syndrome, and premature or impending myocardial infarction. As these names imply, unstable angina presents as a clinical syndrome that falls between stable angina and an MI and represents an imbalance between myocardial oxygen supply and demands. Patients with unstable angina should receive only minimal or emergency dental care after consultation with a physician. Variant angina, also known as Prince-Metal's, atypical, or vasoplastic angina, usually occurs spontaneously. The symptoms are similar to the other forms of angina, or the majority of these anginal episodes occur while the patient is at rest. Neither emotional stress nor physical exertion trigger the attack. And they also occur at odd hours of the day or night. They are more common in women under 50 and those thought to be at low risk for coronary artery disease. A transient spasm of a coronary artery causing a brief occlusion of the vessel is thought to precipitate an attack. Anginal attacks often occur when additional stress is placed on the heart muscle and it requires an enhanced blood supply, which is not available. Common factors that lead to anginal attacks are increased physical exertion or exercise, encountering a stressful situation, eating a heavy meal, or moving to a high altitude. As discussed previously, typical angina is characterized by generalized chest discomfort. This discomfort is often described as a pressure or a burning or heaviness or squeezing or choking sensation, which often radiates from the thoracic area to a shoulder, usually the left, down to the arm and to the neck, lower jaw, or tongue. In many cases, diaphoresis, nausea, and pallor are present along with some dyspnea. During an acute anginal episode, the patient may be notably apprehensive, may press his or her fist to their sternum, which is known as a Levine sign, and their heart rate and blood pressure may be significantly elevated. The primary goal in the treatment of an anginal episode is to decrease the myocardium's demand for oxygen. If the patient experiences an anginal episode during treatment, the procedure should be terminated and the patient should be placed in a semi-supine or upright position. The airway, breathing, and circulation should be assessed. Oxygen at 100% via nasal cannula or non-rebreather mask can be administered at any time during the management of this medical emergency. Vital signs should be monitored throughout the treatment of the anginal episode. Once these basic measures have been completed, you should ask the patient about their symptoms. If Manny states that they are typical of a normal anginal attack, then you would continue treating it as such. However, if Manny informed you that the discomfort is much more severe than normal, then EMS should be contacted immediately, and the patient should be treated as an MI, which will be discussed shortly. Assuming that the patient is conscious, a sublingual tablet or a transmucosal spray of nitroglycerin should be administered immediately. It is preferable to use the patient's own nitroglycerin if possible because the dosage will be accurate for that patient, usually 0.3 to 0.6 milligrams. If the patient's nitroglycerin is outdated or has lost potency due to improper storage, use the fresh nitroglycerin stored in your emergency kit. You can tell if the drug is still potent if the patient experiences a tingling sensation on the tongue as the tablet dissolves. If sublingual tablets are used, administer 1 tablet every 5 minutes, not to exceed 3 tablets every 15 minutes. If using the nitrolingual spray, 1 or 2 metered sprays are recommended initially with no more than 3 meter doses within a 15-minute period. Nitroglycerin dilates the coronary blood vessels, resulting in a decrease in cardiac workload. This results in a decrease in the demand for oxygen by the myocardium. The administration of nitroglycerin normally reduces or eliminates anginal pain within 2 to 4 minutes. The administration of nitroglycerin is contraindicated in patients with hypotension, so be sure to take the patient's blood pressure prior to administration. Following the administration of the drug, the patient may experience tachycardia, flushing, and a pounding or fullness in the head, as well as possible hypotension. Dental treatment may be resumed if the patient feels well enough to continue. However, it may be more prudent to reschedule the patient and complete the treatment at another appointment. If the chest pain is not relieved by 2 dosages of nitroglycerin, either with spray or tablet, over a 10-minute time frame, or if the patient states that the pain is more severe than they have previously experienced, then EMS should be contacted immediately. If the patient has no known history of angina pectoris and the chest pain persists for 2 minutes or longer, again, 911 should also be immediately activated. In Manny's case, if his chest pain did not subside, acute myocardial infarction should be strongly considered. Acute myocardial infarction is a necrosis or death of a portion of the myocardium due to total or partial occlusion of a coronary artery. An occlusion is often caused by atherosclerosis, or it can be caused by a thrombus or even a spasm of the coronary artery. It may form rapidly or occur over a prolonged period of time. Anyone experiencing an MI is at risk for going into complete cardiac arrest where the heart fails to beat at all. 1.5 million Americans have experienced an AMI, and it is the -- cause of death. A number of years ago, we had a patient in our clinic who complained of severe indigestion. So much so that he was going to walk himself over to the nearby emergency department. At that point, I decided that it was best that he stay with us and we call EMS to bring him there. We monitored his vital signs until EMS arrived. Upon arrival, they attached him to the EKG, which seemed normal. As they were wheeling him out of the clinic on a gurney, he went into full cardiac arrest. Thankfully, they were able to revive him, and he lived for several more years after the MI. Survival from an acute myocardial infarction is dependent upon early and appropriate treatment, and recognition of the signs and symptoms is critical. The classic symptoms of an AMI is chest pain or discomfort that lasts 20 minutes or longer. Typically, victims describe feeling pressure, tightness, heaviness, burning, squeezing, or a crushing sensation in the middle of the chest and or lower third of the epigastrum. The pain may radiate down the arm, shoulders, neck, jaw, or back. I actually did a medical emergency course in New York City one time where a dentist did say that he had a patient that came in for a toothache, and there was absolutely no evidence of decay, and all the symptoms were related to an MI, and the patient was transported to the emergency department where he was actually having an MI. The victim may also experience weakness, dyspnea, diaphoresis, and an irregular pulse. Their skin is often described as ashen gray. Nausea and vomiting may occur, especially if the pain is intense. In addition, patients experiencing an AMI may seem very apprehensive and express an intense sense of impending doom. They often, again, clutch their fists to their chest in the classic Levine sign. If left untreated, cardiac arrest will result and the patient will have no pulse, respirations, or blood pressure. In the dental setting, treatment should be stopped immediately with the onset of chest pain. If the patient has a history of angina, the steps for the treatment of an anginal episode should be initiated. If the patient has no history of angina, the situation should be treated as if it is an MI, which includes positioning the patient in a comfortable position, assessing the airway, breathing, and circulation, and activating the EMS system immediately. If the patient is experiencing dyspnea, oxygen should be administered via nasal cannula or non-rebreather mask at a flow rate of 4 to 6 liters per minute. If the patient has no history of angina pectoris, nitroglycerin from the emergency kit should be administered. Vital signs should be recorded prior to administering the nitroglycerin and immediately afterward. As stated previously, nitroglycerin should not be administered to patients with a systolic blood pressure less than 90 millimeters of mercury. If the patient is suffering from an anginal attack, the nitroglycerin should act to alleviate the pain within 2 to 4 minutes. If the pain continues following the administration of 3 doses of nitroglycerin over a 15-minute time period, or if the pain diminishes and then returns, the situation should be managed as an MI. Fibrinolysis should be initiated as soon as the symptoms are identified as those of an MI. Aspirin has a proven antithrombotic effect and assists in revascularization of the myocardium during an ischemic attack. It is recommended that out-of-hospital MI victims are administered a single chew dose of 162 to 325 milligrams of aspirin as soon as an MI is recognized. Chewing the tablet permits the acetylsalicylic acid to be absorbed through the oral mucous membranes and enter the bloodstream more quickly. We recommend 4-baby aspirin as their flavor is much more tolerable than regular aspirin. When chewed, the clinical effects of the aspirin are realized in about 20 minutes. When swallowed, the clinical effects of the drug are delayed considerably. Vital signs should continue to be monitored and recorded every 5 minutes. Management of pain while waiting for EMTs to arrive may be required to help to prevent cardiogenic shock. Nitroglycerin is usually inadequate for the relief of pain associated with an MI. Opioid analgesics, either morphine or meperidine, are recommended, but are not usually available in the dental setting. However, the analgesic properties of nitrous oxide and oxygen provide a good alternative and are usually available in the dental setting. If nitrous oxide is available, deliver a flow of 3.5 to 4 liters of nitrous oxide and a flow of 6.9 to 6.5 liters per minute of oxygen. This will usually manage the pain completely or reduce it to a tolerable level. If the patient goes into full cardiac arrest at any time during the management of a myocardial infarction, EMS should be immediately contacted. The patient should be placed in a supine position, and CPR should begin immediately using forced oxygen via a bag mask at 15 liters per minute until EMS arrives. Because ventricular fibrillation, or VF, occurs in about 90% of all cardiac arrests, defibrillation may be required. Healthcare providers should be trained in the use of an automated external defibrillator and be ready to use one if available. According to the American Heart Association, for victims of a witnessed cardiac arrest with VF, The immediate initiation of CPR and use of an AED within the first 3 to 5 minutes provides the highest chance for victim survival. Once the patient reaches the hospital, various tests will be performed to determine the severity of the condition and to determine the appropriate treatment. Possible treatments include angioplasty, stents, or coronary bypass. My dad, who happens to be in this photo, had an MI in 2008. He had quadruple bypass, followed by the placement of a pacemaker, which was later replaced with an ICD, and is still with us today. He is 93. I should also add that my mom is 97, so yes, there is longevity in my family. So once Manny has recovered from his MI and any medical procedures and returns to your office, he should not have any elective treatment for 45 days. When you're able to treat him, you should pay particular attention to the medications that he is taking. If he is taking anticoagulants such as Coumadin, he should have his INR or international normalized ratio checked prior to treatment to ensure proper clotting. The acceptable range for the INR is between 2 and 3. However, there are many more anticoagulant medications available than there once were. Some of those medications include Eliquis, Plavix, Pradaxa, and Xarelto. These medications do not require routine INR testing. If you have any question regarding a patient's medical condition, consulting with their physician is strongly advised. So, another poll, just to break things up a little bit. What is the most common medication used to treat an anginal attack? Aspirin, diazepam, nitroglycerin, or oxygen? Excellent. So the majority of you are selecting nitroglycerin, which is that coronary vasodilator, and the correct answer. Aspirin is used more for a MI, not necessarily for an anginal attack. So now Manny returns to your office for his dental hygiene 8 months after experiencing an AMI. After having quadruple bypass surgery, a pacemaker was placed to help control his bradycardia. And that is usually why they place pacemakers, is due to bradycardia. Since Manny is now overdue for his dental hygiene, you find moderate deposits on his teeth. You decide that the ultrasonic scaler would be easier for both you and the patient. Now, obviously, in our COVID-19 world, you would only use an ultrasonic scaler with the appropriate PPE and high volume evacuation. You begin the ultrasonic scaling procedure, and suddenly the patient begins to complain of chest pain, dyspnea, dizziness, and is constantly hiccuping. You take his pulse, and it is very slow and weak at 50 beats per minute. His blood pressure is 98/72. What do you think might be happening to your patient? More than likely, Manny is experiencing a pacemaker malfunction. As our population ages, cardiac pacemakers and ICDs will become increasingly more common in our dental patients. Estimates state that there are 3.25 million cardiac pacemakers and 180,000 ICDs worldwide. With 43 million people suffering from cardiovascular disease in the United States, more than half the population over the age of 75 affected by cardiovascular disease, it is reasonable to assume that the number of pacemaker and ICD implants will rise. So a pacemaker is a device composed of a pulse generator and leads. The generator contains the electronic circuitry that powers the device and is a small metal box no larger than 2 stacked silver dollars. The generator is implanted subcutaneously, usually in the clavicle region of the chest wall. Longevity of a generator is approximately 7 to 10 years, And I can attest to that because my dad just had his replaced last May and it was about 10 years old. The leads are the connection between the heart muscle and the generator. They are inserted into the venous system and are maneuvered to the area of the heart requiring stimulation. The leads monitor the heart rate and they provide the pacing impulses when necessary. An ICD is a similar device with the exception that the lead in the ventricle can also provide cardioversion or defibrillation current if needed. The greatest risk of malfunction with pacemakers or ICDs is with electromagnetic interference. The electrical interference is interpreted by the pacemaker as cardiac electrical activity and may inhibit the pacemaker from functioning. This situation is temporary and does not usually cause permanent damage to the pacemaker. Pacemakers and ICDs are protected from interference by shielding of the circuitry inside a stainless steel or titanium case, which filters the incoming signals. There are many causes of pacemaker and ICD malfunction, ranging from cellular phones to MRIs. Patients should be informed by their physician regarding possible causes of interference, and patients need to take appropriate precautions in their everyday life. In addition, they should carry a card stating that they have a pacemaker or ICD. The dental office poses really only a minimal risk to patients with pacemakers or ICDs, as most dental equipment does not involve strong electromagnetic signals. Those procedures performed in the dental office that are considered safe for pacemaker and ICD patients are dental radiographs, the use of dental handpieces, composite curing lights, sonic and piezoelectric ultrasonic scalers. Dental devices in which some controversy exists as to their safety with pacemakers and ICDs are older ferromagnetic ultrasonic scalers, magnetostrictive ultrasonic scalers, TENS units or transcutaneous electrical nerve stimulators, ultrasonic cleaning baths, and electrosurgical units. Malfunction was more common in older implant models. In the present case scenario, the magnetostrictive ultrasonic scaler was placed in too close a proximity for Manny's pacemaker, causing the malfunction, although most pacemaker manufacturing companies assert that there is a low potential for interference. As I said, my dad has an ICD, and I recently used a magnetostrictive ultrasonic scaler while performing his oral prophylaxis with no complications. I did monitor him very carefully for any signs or symptoms of malfunction and would have stopped using it if I had seen any. Although electric and most battery-operated toothbrushes are safe to use with these patients, sonic toothbrushes with a battery charger need to be used with caution. A distance of 6 inches between the charger base and the implanted device should be maintained at all times. My dad also uses a Sonicare toothbrush daily, and his pacemaker has never malfunctioned. Although local anesthetics can be used on patients with pacemakers and ICDs, agents with vasoconstrictors should be used with caution, as with all patients with cardiovascular disease. The amount of vasoconstrictors should be carefully monitored to avoid the development of a dysrhythmia. The symptoms associated with a pacemaker malfunction are related to the pacemaker inhibiting itself from giving pacing impulses as it erroneously interprets the external impulses as heartbeats. The symptoms a patient would most likely experience include lightheadedness, dizziness, dyspnea, moist pale skin, bradycardia or tachycardia, and that depends upon the reason why they implanted the pacemaker initially, chest pain, possible swelling in the extremities, prolonged hiccuping, muscular twitching, and possible altered status. Once the interference is terminated or stopped, the symptoms usually subside and the pacemaker resumes normal operation. In some more severe cases, syncope may occur and you would need to treat that syncopal episode accordingly. The first and most important step of the management of pacemaker or ICD malfunction is to turn off all suspected causes of interference. At that point, assess the patient's consciousness level. If the patient is conscious, which most likely they will be, Take the vital signs and check their pulse rate. The pulse rate should be continuously monitored to determine if it has reverted to a normal rhythm, which more than likely will occur. If it has not reverted to normal, EMS should be contacted and the patient should be transported to the nearest emergency department for treatment. If the patient loses consciousness, you should initially treat for syncope, which includes monitoring vital signs. If the patient does not regain consciousness, this should be considered an extremely serious condition, and 911 should be contacted to have the patient gain the emergent care they require. BLS should be provided until EMS arrives. So another poll. Which of the following equipment in the dental office might possibly cause pacemaker malfunction? Magnetostrictive ultrasonic scaling devices, curing lights, radiographs, all of the above are safe. So as I said, and most of you have this right, magnetostrictive ultrasonic scaling devices, there is some possibility of a minimal risk. However, for the most part, they are all safe to use. In our fourth emergency scenario, your patient, Steve Smith, is a 55-year-old salesperson who reports a history of hypertension, usually 160 over 110. He smokes 2 packs of cigarettes per day and has a drink or 2 with dinner to calm his nerves. He takes Cardizem for his hypertension. Just prior to leaving for his appointment, Steve had an argument with his boss and he is still quite upset. Since he has a history of hypertension, you take his blood pressure and find that it is 190 over 124. He begins to complain of acute headache, dizziness, and a tingling feeling on his right side. You notice that his speech is slurred and his breathing is labored. He remains conscious. Steve is most likely experiencing a CVA, also known as a cerebrovascular accident or stroke. A CVA is an abnormal condition of the brain characterized by occlusion or hemorrhage of a blood vessel, resulting in a lack of oxygen to the brain tissues or ischemia that normally receive their blood supply from the damaged vessels. This lack of blood supply to the blood vessels results in the loss of proper oxygenation to the brain cells and eventually cell death. CVA can lead to paralysis of the individual or in some cases death as well. Recently, there has been a move to use the words brain attack instead of stroke so that the public will become as familiar with its signs and symptoms as they are with a heart attack, in an attempt to reduce the number of disabilities and deaths resulting from this potentially devastating condition. In the U.S., CVA is ranked as the 5th leading cause of death and disability, with at least 750,000 new cases per year. This information was before COVID-19, so now it is probably the 6th leading cause of death and disability. In addition, there are approximately 185,000 recurrent strokes each year. There are several risk factors for CVA. For example, CVA is more often encountered by individuals over 65 years of age, and Blacks seem to be more susceptible than Caucasians. These two groups are more likely to suffer from CVAs as they tend to have a higher incidence of hypertension, which is often a result of atherosclerosis. The atherosclerotic plaques on the blood vessel walls in time tend to form clots, which are the major causes of CVA. Another group of individuals that are more susceptible to CVAs are those suffering from atrial fibrillation, which is a condition that affects approximately 2 million Americans. When a patient is experiencing atrial fibrillation, the 2 atria of the heart quiver instead of beating properly. This causes the heart to pump blood inefficiently, and the result is pooling of blood with subsequent formation of thrombi. Thrombi are blockages at their point of origin composed of various substances such as platelets, fibrin, and cellular elements. Atrial fibrillation increases the likelihood of stroke fivefold, and the risk increases as the individual ages or is combined with hypertension, diabetes, a previous CVA, or a TIA, which I'll talk about momentarily. Diabetic patients also have a higher risk of suffering from CVA, as do patients who have previously experienced a CVA or have a familial history of CVA. In addition, individuals who have experienced a TIA or transient ischemic attack are highly susceptible to CVA. TIAs are a brief episode of neurological dysfunction caused by ischemia of the brain in a specific location with symptoms lasting less than 1 hour with no evidence of an acute stroke. Approximately 200,000 to 500,000 Americans suffer from TIAs annually. It is estimated that 10% of all strokes are preceded by a TIA. CVAs often occur within the first 4 days of the TIA, so patients need to be counseled regarding their seriousness. This actually occurred to my mother-in-law, who initially experienced a TIA, was discharged from the hospital, and within hours experienced a full cerebrovascular accident, unfortunately. There's 2 basic types of CVA. One is ischemic and the other is hemorrhagic. The ischemic type occurs when there is some form of blockage in a cerebral blood vessel. The blockage can either be a thrombus, which is a blockage at the point of origin, or an embolus, which is a foreign object, either a quantity of air or gas or a thrombus that originated elsewhere in the body and then circulates to another area where it becomes lodged in the blood vessel. In the case of a CVA, it becomes lodged in a blood vessel within the brain. The ischemic type of CVA occurs in 85% of patients, with 60% being thrombotic and 40% being embolic CVAs. The other type of CVA is a hemorrhagic and occurs as a result of the rupture of a blood vessel in the brain. Approximately 15% of all strokes are of the hemorrhagic type. There is a 50 to 70% mortality rate with this type of CVA. However, those that do survive actually tend to have a better recovery. This is due to the fact that if the hemorrhagic stroke is treated and the patient survives, the pressure that is causing the damage gradually diminishes and the patient tends to regain some of its former function. In the hemorrhagic strokes, the bleeding compresses nearby blood vessels and deprives surrounding tissue of oxygen. The cerebral ischemia causes brain tissue to become edematous, which is not acceptable to brain function. Due to the dental office being stressful to some individuals, the hemorrhagic type of CVA is more common in this setting versus the thrombotic type. There are several factors that can lead to hemorrhagic stroke, such as anticoagulation, tumor, substance abuse, the use of cocaine, amphetamines, or alcohol, and hypertension. Hypertension leads to degenerative changes in the blood vessel walls, whereby tearing is more likely. For every 10 millimeters of mercury of systolic blood pressure above 160, there is a 30% greater risk of CVA occurring. In addition, some individuals may have an aneurysm, which is a weakening or ballooning of a blood vessel, and with added pressure, such as hypertension, the blood vessel ruptures and causes the stroke. There are many signs and symptoms associated with ischemic stroke. The signs and symptoms may stop and start again and as the stroke progresses. In addition, the severity and location of the stroke influences the symptoms that are exhibited by the afflicted individual. The one major difference between the signs and symptoms of embolic and thrombotic strokes are in their onset. Embolic strokes tend to have an abrupt onset, whereas with thrombotic strokes, the onset is often difficult to determine as the symptoms are often not as severe. The signs and symptoms shared by both types of ischemic stroke include an altered level of consciousness from yawning to coma. That's possible. However, as I said, total loss of consciousness is uncommon. The pupils may be unequal and dilated. Confusion and dizziness may be apparent, and there may be a notable change in balance or coordination, also referred to as ataxia. Vision changes, including double vision and blind spots, may occur. Hemianopia, the loss of vision in half of the visual field in one or both eyes, may occur. Speech changes are common and can range from poorly articulated speech, referred to as dysarthria. I think I have that right now. Impairment of speech, dysphagia, to the inability to understand spoken words, to the most severe form, which is the inability to speak at all, known as aphasia. Difficulty swallowing, deviation of the tongue, and drooling are also common symptoms of ischemic stroke. Weakness, numbness, or tingling in the face, usually on only one side, and results in facial droop, often occurs, as does weakness, numbness, or tingling in an arm or leg, or both, usually on one side of the body, referred to as hemiparesis. Nausea and vomiting may occur after some time due to increased intracranial pressure. The signs and symptoms of hemorrhagic stroke have many similarities with the ischemic stroke type, although there are some differences. Severe headache is twice as common in hemorrhagic stroke versus ischemic stroke. 2/3 of all individuals experiencing hemorrhagic stroke will endure an acute headache, commonly occurring in the occipital region. High blood pressure readings are commonly found in hemorrhagic CVA patients. The inability to stand or walk and pupillary malalignment are also signs of hemorrhagic CVA. And also nausea and vomiting are also very common. The patient might also experience an altered level of consciousness from yawning to coma. There are several stroke scales that can be used to help determine whether a patient is suffering from a CVA. The one that I like best is the Cincinnati Pre-Hospital Stroke Scale. This survey includes 3 components which have been consistently identified in individuals with CVA: facial palsy, arm motor weakness, and dysarthria. The stroke scale is administered as follows. The patient is asked to smile while the healthcare provider observes the patient for weakness on one side of the face. The patient is asked to hold both arms out with palm up and eyes closed for 10 seconds while the healthcare provider observes for a weakness in one arm. If there are weakness in both arms or if normal strength is determined, then the patient tests negative for CVA. The patient is asked to repeat a simple sentence, "The sky is blue in Cincinnati," while the healthcare provider observes for difficulty in speech. If any of the 3 components are found to be abnormal, then it should be assumed that they are experiencing a stroke and should be treated as such. Another stroke scale that was developed subsequent to the Cincinnati Pre-Hospital Stroke Scale is the FAST algorithm. The FAST mnemonic was developed in 1998 by a group of stroke physicians, ambulance personnel, and emergency department physicians in the UK to help expedite the administration of TPA to patients within 3 hours of the onset of stroke symptoms. The F in FAST stands for face. With this scale, you ask the person to smile and look for one side of the face to droop. The A stands for arms. You should ask the person to raise both arms and look to see if one arm drifts downward or is not able to be raised at all. The S, which stands for speech, you should ask the person to repeat a simple phrase and determine if the speech is slurred or strange. For the T, which stands for time, if you see any of the above signs, you should call 911 right away. You should note the time when the symptoms first appear, as this information will help healthcare providers determine the best treatment for the patient. The primary goal of CVA treatment is to minimize the cognitive and physical limitations associated with a cerebral ischemia or hemorrhage. If the patient exhibits any signs of CVA, EMS should be contacted immediately. The patient should be positioned semi-supinely. Basic life support should be initiated by checking the ABCs. Fortunately, most patients suffering from CVA, and particularly ischemic stroke, are able to maintain their own airway, breathing, and circulation during the beginning stages of the event. Oxygen should only be administered if the patient is having dyspnea or shows signs of hypoxia. There is some evidence that suggests that additional oxygen may worsen the outcome for the patient. The patient's glucose levels should be tested, particularly since hypoglycemia may mimic stroke symptoms, so it needs to be ruled out as an etiology. Vital signs should be continuously monitored, and the patient should be transported to the emergency department as soon as possible. The importance of transporting the patient to an emergency department that is well equipped to handle CVA patients cannot be overemphasized. Once hospitalized, patients suspected of having some form of CVA need to undergo a computer tomography or CT scan to determine the exact etiology of the symptoms. If the scan indicates a hemorrhagic stroke, the patient will require consultation with a neurosurgeon, and most probably surgery will be performed. If the scan reveals an ischemic stroke and the onset of the symptom has been less than 3 hours, then the current treatment is intravenous thrombolytic therapy with the medication alteplase. Alteplase is a recombinant tissue plasminogen activator, which is often referred to as RTPA. The thrombolytic agent helps to remove the thrombus or embolus in the cerebral blood vessel, thereby restoring blood flow to the area. The use of RTPA after the 3-hour window has been shown to be ineffective. Therefore, prompt medical attention is imperative for suspected CVA patients. So let's go to another poll. So all of the following are symptoms of CVA except blurred vision, speech defects, hemiparesis, or unconsciousness. Great. Most of you are paying attention. With usually patients that suffer from CVA do not lose consciousness. They do often have blurred vision. They do often have speech defects, again, depending upon which part of the brain is affected by the CVA. They do often have hemiparesis, which is paralysis on one side of the body. And our last emergency situation for this course is with your patient, 34-year-old Harriet Hogan, and she's scheduled for the placement of a composite restoration on number 3. She informs you that this is not a pleasant experience for her. She has no positive findings on her medical history, but today she seems unusually anxious and complains of being dizzy and lightheaded. Just prior to the anesthetic injection, she begins to breathe quite rapidly and deeply. She cannot seem to catch her breath. Harriet is most likely experiencing hyperventilation syndrome, which is a condition where the patient breathes faster and or deeper than the metabolic needs of the body, thus eliminating more carbon dioxide than is being produced. The normal respiration rate for an adult is 10 to 16 respirations per minute and rarely exceeds 22 breaths per minute. A patient who is hyperventilating may experience a respiration rate between 22 to 40 breaths per minute. Hyperventilation syndrome reportedly affects 6 to 15% of the population and is predominantly found in females in the 30 to 40 year age range. This syndrome is common when individuals are exposed to high altitudes, are pregnant, take central nervous system drugs, have aspirin toxicity, and experience anxiety states. Fear and anxiety are common precipitating factors in the dental setting and can cause hyperventilation. We have had a few dental hygiene students experience hyperventilation, particularly when they're about to be evaluated in clinic. Hyperventilation is characterized by the lack of carbon dioxide in the arterial blood system, resulting in respiratory alkalosis. Respiratory alkalosis is an increase in the pH of the circulating blood. The optimal pH for the blood is 7.4, which is slightly alkaline. By increasing respirations, the pH will rise to 7.5 or higher. This minor change in blood pH can have significant physiologic effects and can manifest as the particular symptoms that are being exhibited by Harriet. The most common symptoms of hyperventilation syndrome are abnormally prolonged rapid and deep respirations. This breathing pattern leads to changes in the patient's blood chemistry. The combined high pH or alkaline of the blood and low carbon dioxide leads to certain body changes. The decrease in carbon dioxide causes vasoconstriction of the arteries and veins in areas of the body, including the heart and the brain. The vasoconstriction of the blood vessels in the heart leads to a decreased cardiac output and reduced coronary blood flow, which will give the patient the symptoms of heart palpitations and possibly chest pain. Hyperventilation has also been shown to impair problem-solving abilities, motor coordination, balance, and perceptual tasks. These symptoms are related to the improper cerebral oxygenation. The vasoconstriction of the blood vessels in the brain can lead to feelings of lightheadedness, dizziness, and impaired vision. In addition, this destabilization of the brain can easily hasten seizures. Other symptoms associated with hyperventilation are apprehension and diaphoresis or extreme sweating. The patient might also exhibit trembling, fatigue, and circumoral paresthesia or numbness or tingling around the oral cavity. Moreover, the patient may experience brief episodes of unconsciousness followed by stress-induced deep, rapid breathing. Progressive hyperventilation has been shown to cause hypocalcemia, which is a reduction in the calcium levels in the bloodstream. This condition can lead to tetany, which manifests clinically as twitching of the muscles or spasms with sharp flexion of the wrist and ankle joints, also called carpopedal spasms. These spasms might also be accompanied by paresthesia or numbness in the extremities. Once a diagnosis of hyperventilation has been determined, therapy is directed at alleviating the symptoms. The basic premise for treatment is to increase blood carbon dioxide levels while addressing the psychological factors the patient is experiencing. The operator needs to remain calm, keep a non-judgmental attitude. Breathing into a paper bag was once the well-known cure for hyperventilation. This treatment modality is no longer recommended. Several studies noted by Callahan have indicated that breathing into a paper bag caused suffocation or even cardiac arrest. The recommended treatment is to place the patient in the position of their choice, which is usually sitting upright. In addition, loosen tight clothing around the neck region. The next most important step is to work with the patient to control the rate of respirations. Having the patient count to 10 in one breath is very helpful. Breathing through pursed lips or breathing through the nose will also help slow breathing. While attempting to control breathing, the respiratory rate, pulse rates, and blood pressure should be monitored. You can also have the patient breathe into their cupped hands that cover their mouth and nose. If the condition does not improve, the healthcare professional should the patient should be transported by EMS to an emergency department to determine if the patient may be suffering from a more serious condition, such as pulmonary embolism. And our last poll. is the best treatment for hyperventilation is to breathe into a paper bag, work with the patient to control breathing, administer oxygen via a non-rebreather bag, or administer lorazepam. So in actuality, administering oxygen could actually make it worse. The patient actually has too much oxygen. That's the problem. So we don't want to administer oxygen. It probably won't do much damage, but it won't do much good. The answer is to work with the patient to control their breathing. And as I said, breathing into a paper bag can cause cardiac arrest, so we shouldn't use that anymore. You can administer lorazepam, but of course that can only be administered by a trained professional. So that concludes my presentation. I do see that there were some questions, and I'll try to answer them. Okay, so one question was, is it mandatory to have an automated external defibrillator in the dental office? No, it is not mandatory, but I think it is a great thing to have in case an MI were to happen in your dental office. Oh, one of my former students wanted to say hi. Nice to see you. Someone recommended try offering them a piece of gum to get their breathing under control. Sounds like a great idea. Anything for hyperventilation, that would be a great, anything that can get their minds off of them trying to breathe too deeply. Someone asked for the reference regarding cardiac arrest risk for breathing into a paper bag. The reference is actually in my textbook. Unfortunately, I don't have that off the top of my head, but it is in my textbook. Is it mandatory to have a medical kit at the office? It's not mandatory, but I certainly think that you should have one. I just can't imagine that you wouldn't. Do you recommend using ammonia inhalers for syncope? Actually, no, I don't recommend using ammonia. All the research that I've done, it actually says that it is not needed, and in some instances can actually cause more harm than good as well. So if a patient routinely has syncope during the administration of local anesthetic but recovers and is fine, should treatment be discontinued? I guess I would have to say that I think that you really need to use your best judgment. Hopefully, if they continuously have syncope with local administration, that would be the type of patient that you might want to give some, have the dentist prescribe diazepam prior to their dental treatment so that they're calmer when they come into the office. And I guess my time is up. Thank you all for attending. I hope you learned something.